Good morning, ladies and gentlemen. On behalf of Sri Lanka Medical Association, I would like to welcome you all to this expert talk on leptospirosis. This is a collaboration between Sri Lanka Medical Association and the Epidemiology Unit of Ministry of Health. Now, this expert talk is the latest knowledge dissemination platform of Sri Lanka Medical Association, where public health institutions as well as curative institutions can showcase their collaborative work to a large audience of clinicians as well as public health professionals. So, start off the proceedings, I would like to invite you to rise for the national anthem. Start of the formal proceedings, I would like to invite following dignitaries to light the traditional oil lamp. Dr. Vinya Ariratna, President, Sri Lanka Medical Association. Dr. Lushan Jayasuriya, former President, Sri Lanka Medical Association. Dr. Tushani Dabrera, Consultant Committee Physician, Epidemiology Unit, Ministry of Health. Dr. Vimalasiri Uluvattage, Consultant Physician, Teaching Hospital, Karapitiya. Dr. Lilani Karunanayaka, Consultant Clinical Microbiologist, Medical Research Institute. Dr. Athula Liena Pathirana, Consultant Committee Physician, Epidemiology Unit. Sir, Madam. Thank you, sir, madam. Now I would like to invite Dr. Vinya Ariratna, President, Sri Lanka Medical Association, Dr. Tushani Dabrera, Epidemiology Unit, Dr. Vimalasiri Uluvattage, Consultant Physician, Teaching Hospital, Karapitiya, and Dr. Lilani Karunanayaka, Consultant Clinical Microbiologist, Medical Research Institute, to grace the head table. Thank you, sir, madam. Now, this year in 2023, Sri Lanka Medical Association has chosen the theme of excellence, equity, and community as its thematic area. Now, we have been conducting several knowledge sharing sessions, knowledge dissemination sessions throughout this year. in collaboration with different public health institutions as well as curative institutions. Now, this expert talk is the latest addition to these knowledge dissemination platforms, where we engage with clinicians as well as public health experts to update our fellow colleagues as well as clinicians and public health professionals on subjects that are of national concern. So, to start off the formal proceedings, technical session, I would like to invite Dr. Vinya Ariratna, President, Sri Lanka Medical Association, to update you on the objectives of this session and to welcome you all on behalf of Sri Lanka Medical Association. Over to you, sir.
Thank you, Lahiru. Good morning. Dr. Lushan Jayasuriya, our Senior Past President of Sri Lanka Medical Association, and our resource persons today, Dr. Vimalasiri Uluwattage and also Dr. Tushani Dabrera and Dr. Lilani Karunanayaka and the other speaker, Dr. Kodituaku, is yet to come. I would like to, on behalf of the Sri Lanka Medical Association, very warmly welcome all of you, and also those of you who are here today attending this important session in person, and also those of you who are joining us joining online through Zoom. I think this is a very important topic today, and we have selected deliberately topics that are not being discussed that much even in clinical settings or in our public health sessions. So as Dr. Kodituaku mentioned, the series of sessions, expert talks, is to really focus on one particular public health issue or a health issue that is of great importance, and also try to bring together different perspectives from preventive to public health to clinical, diagnostic, all that in one brief session. And this is meant to be for our practitioners as well as for students. So SLMA is very happy that we are able to have this session by the panel of experts that we have invited today, who are very well experienced and knowledgeable on this topic. And as Lahiru mentioned, this year's theme is towards humane healthcare, excellence, equity and community. When we look at healthcare, we need to remind ourselves of ethical practices and also how we achieve within certain resource constraints that we are facing today as a country because of the economic downturn, to provide the best of care for our patients and also provide services in relation to health promotion and prevention. So in doing that, we have to maintain excellent standards that are expected from us as medical practitioners or providers. That's why we have the first sub-theme, excellence. So excellence in every aspect, whether it is in diagnosis or treatment or prevention, we would like to remind ourselves of excellence and also provide the necessary up-to-date information to all the stakeholders in the healthcare sector. Then equity. We know that there are a lot of inequalities in our health outcomes in the country. Even if you take very standard indicators such as the infant mortality rate or maternal mortality rate, although as a country we can be very proud and we are happy that we have achieved a very high standard of healthcare based on these indicators. If you look at the distribution of the same indicator by districts or by socio-economic groups or sometimes even by ethnic groups, we see unacceptable disparities or differences. So that's where we need to apply the principle of equity. So we see, particularly in a disease like leptospirosis, which is directly related to an occupation that is very important to the economy. It's the backbone of our economy, the agriculture. 30% of our population is engaged in agriculture, even though its contribution to GDP is only 7%. As an occupation, as a lifestyle, as a culture, agriculture is an integral part of our civilization, our society. Therefore, leptospirosis, which is connected from an occupational health point of view to agriculture and farmers, I think it's of even more importance that we address this issue. So we are very happy as SLMA to host this seminar in partnership with the epidemiology unit, and I would also like to acknowledge the presence of Dr. Lionel from the consultant community physician from the EPID unit, and thank you Atula for also joining with SLMA on behalf of the EPID unit to conduct this, and in the future also we look forward to working with the EPID unit and also other stakeholders in addressing important public health issues in Sri Lanka. Once again, I welcome all of you and I wish the deliberations all success. Thank you.
Thank you very much, sir, for highlighting the importance of integration of public health and curative health. So I'll now hand over the podium to Dr. Ravindu Kodituaku, who is a registrar in medicine. He will be conducting the technical session here onwards. Dr. Ravindu.
Good morning all. Thank you, Dr. Lahiri, for the introduction. So starting our session today, we will be covering leptospirosis on 3 aspects, including the epidemiology, the laboratory diagnosis, and also the clinical aspect of it. To start off our session, I would like to invite Dr. Tushani Dabre, Consultant Community Physician, Epidemiology Unit, Ministry of Health, and her topic will be epidemiology of leptospirosis. Over to you, madam.
President, past presidents, and officials of the SLMA, colleagues, and those who are joining online. Good morning. A brief introduction to the epidemiology of leptospirosis, mainly data from our country, and we have to talk about leptospirosis because it is known as a neglected disease, neglected tropical disease, but it is not neglected by the clinicians and the other doctors of the hospitals who are working, as they very well know. It is a bacterial disease and thought to be the most widespread zoonosis in the world. And it is a global emerging public health problem because it is underreported. We don't know how many patients are there at one given moment, and often misdiagnosed. And it may mimic certain communicable diseases of international concerns like yellow fever and malaria. So this is emerging as a very big problem. And the global burden of disease, it is very difficult to talk about this because there are no reliable global estimates. And some research, they estimate that annually there could be about 1 million cases throughout the world, 60,000 deaths, and the young males will be affected. And it is shown in our as estimates as well, what we have in the Sri Lankan databases. And the geographical distribution is such that it is prevalent in the tropical and subtropical areas of the world. As you may see, it is a belt, and we see that the most poorest, resource-poor countries are affected. And mammals are the carriers of this bacteria, and rodents are the most important reservoir in transmission. It is true in Sri Lanka as well. The bacteria is found in cattle, pigs, dogs, horses, sheep, and goats as well. The bacteria lives in the renal tubules of the mammals. And in the environment, the bacteria can survive in fresh water up to 16 days and in soil for about 24 days. The urine of the infected animal is mixed with water or soil, and that's where we get our risk communities, like the farmers. And these are the well-known reservoir hosts in Sri Lanka. Among them, rat is the most common animal transmitting the disease in Sri Lanka. We will hear this, the scientific evidence later during the presentation of Dr. Lilani Karunanayaka. As you all know, leptospirosis is a notifiable disease, and the number of notified patients reported throughout the years from 2015 shows that the disease is increasing, and it is the second prevalent communicable disease in Sri Lanka. However, there is an underreporting due to several reasons, and as we saw with the global disease data, it should be kept in mind that the number of cases could be 3 times this number. So 7,000 could be 21,000. And when we see the trend, leptospirosis is reported in Sri Lanka throughout the year, but we distinctly see 2 peaks during the Yala and Maha season associated with the monsoons as well. So the preventive activities are conducted mainly during those times. A different trend was seen during 2020 when we see that the numbers peaking later because of many people who took up agriculture getting affected after the lockdown during the COVID-19 pandemic. And Ratnapura district during these years is reporting the highest number of cases. Kegol, Gaul, Kalutara are also report higher numbers. But we need to keep in mind that the whole island could be affected, as many are taking up paddy farming due to economic issues and other reasons. And we may see increased numbers with improved reporting from hospitals when the doctors are made aware of the importance of notifications. Currently, many cases are not reported, even though they are treated as leptospirosis. And this is in 2015, so you see there is a change in the districts. So throughout the years, it can change, but Ratnapura has seen a higher number of cases consistently for the past few years. And when a hospital notifies a patient, the PHI will follow up and submit a special investigation form. And it has individual patient data. The socio-demographic data, clinical aspects, lab investigations, and prophylaxis is included. We can see a pattern in the variables, and our prevention and control activities need to be streamlined to reduce the numbers. So we see that, as with other global evidence, the males are mostly affected, but it might change. And the age groups, we see that the young 20 to 60 group is affected more. They are the active population who are engaged in the economic activities, and when they are ill and hospitalized, the impact will be felt to their families and to the whole country, as Dr. Vinya said. And the occupation, so we get the data, the occupation-wise we see that majority of the patients are farmers, mostly paddy farmers, and most of the other categories are also associated with farming, either as a laborer, the wife of a farmer, or part-time farmers. In Ratnapura, there is a different picture with gem miners being affected with this disease. And as you can see, that the most patients were exposed to muddy or contaminated water or other water sources. And unfortunately, although the prophylaxis is given to high-risk group of paddy farmers, only 3% of the patients have taken prophylaxis. But again, they have received the doxy, but have they taken it? And have they taken the correct dose? We need more evidence, more research to answer the questions related to prophylaxis, because it's a sort of a subject that need to be studied more. And every year, nearly 100 people die due to leptospirosis. This is actually we don't hear much about it. But it is not a popular disease to cry over, write stories in the media, or show heart-rendering videos. Because the majority of people who die are poor and disadvantaged, majority. But those who die are also young and able males who provide us with food. They should not be just numbers. Their death should be noted and the next death prevented. The time is near when all the social classes will be affected as human behavior has changed and the risk occupations and activities are being added to our lives in the changing world. So you see, as with the deaths, the young people are dying, the males are dying, and they have not taken prophylaxis, majority. And who is at risk? The farmers, gem miners, sewerage workers, sand miners were at the highest risk of getting leptospirosis. They still are at risk, but new groups are coming up, and we need to be aware as doctors to prevent, detect, and treat. Housewives who frequent the Kohilo Kirakotu, children playing in the paddy fields, they are getting leptospirosis. With the economic crisis, we need to keep in mind that women and children may engage in agriculture activities. Sri Lanka is looking for dollars by promoting tourism. There were outbreaks in the past associated with whitewater rafting, and ecotourism is actually coming up. So we need to be aware about this, and camping, glamping, and other ecotourism activities are popular with both locals and foreigners. And it is the changing epidemiology that we need to keep an eye on. It is imperative that we note those subtle changes in the epidemiology through strict vigilance. And finally, I'm winding up with this ad shown in the social media. So this is the change in pattern. Maybe we have to think of those as well when we think of the preventive activities. And it is imperative that clinicians think of this and ask the occupational and other water-related, mud-related activities of those people, irrespective of their occupations or their jobs. Thank you very much.
Thank you, madam, for that informative lecture. For our next session on the role of laboratory in the management of leptospirosis, I would like to invite Dr. Lanka, consultant clinical microbiologist of Medical Research Institute. Auditorium.
Good morning, everyone. I would like to thank the Epidemiology Unit and the SLMA for arranging this seminar and for inviting me to talk to you. So I will be talking on role of the laboratory in managing leptospirosis. So for the next few minutes, I will talk to you on, I will make you aware the changing patterns of SEROVA in relation to clinical manifestations of human leptospirosis in Sri Lanka. Then the available microbiological investigations. So at the moment, we are finding difficult even for laboratory testing, but we will see whether we could continue microbiological investigations and whether our microbiological investigations are standardized and quality control. And also, I would like to aware you on the use of the test and their interpretation. So I'll start with the early reports of leptospirosis. The first case was reported by renowned physician Dr. Rajasurya in a patient with Weil's disease in 1953. So laboratory support was established in 1956 at the same institute, Medical Research Institute, at the same laboratory. Now we are continuing the service for 67 years. So the first isolate was Leptospira icterohemorrhagiae from a patient with Weil's disease. So in 1974, Dr. Ramachandran reported the first large case series. As you could see, jaundice was the prominent sign, or the patients had approximately 50% of patients had jaundice in their patients. And there were 6 cultures in that cohort. This is a single hospital series. The 6 cultures, the majority belong to icterohemorrhagiae. As we know, icterohemorrhagiae is the most common SEROVA that will cause Weil's disease with hepatic involvement. In 2012 to 2014, we did a study with the University of Colombo, and you could see now the changing pattern of clinical manifestations. We were able to identify only 25% of our cases. There were 800 cases, only 25% had jaundice. That means we have a problem of anicteric leptospirosis. So these patients, the diagnosis can be easily missed. Then co-infections. We did a study, a prospective study in 3 hospitals in the Western Province in clinically suspected dengue patients. There were about 386 patients and 29 had laboratory confirmed leptospirosis. And there were 6 patients who were clinically suspecting dengue, but they were dengue test negative, but positive for leptospirosis. And also, among the 297 adult patients with confirmed acute dengue infection with the laboratory confirmation, 7.74% had concomitant leptospirosis. Again, in a base hospital, in a pediatric ward, we were able to identify 3 children presenting with fever and abdominal pain, and one also had hematuria, where these children had dengue NS1 antigen and pathogenic Leptospira PCR positive. So co-infections or concomitant infections is also a problem in Sri Lanka right now. Now these children, they were having their vacation and playing in the paddy fields. That was the exposure history. So now you could see the changing SEROVAs. Initially we had icterohemorrhagiae, and it was changed to pyrogenes in 2011, And now the most common serova is pyrogenes and autumnalis. We did a molecular-based study, and most of our cultures were Leptospira interrogans, that is a pathogenic variety, and we were able to identify Kirschneri and Borg-Petersoni. So why I showed those slides, or to make you aware that laboratory diagnosis has now become crucial, unlike early days. So now leptospirosis is a potentially fatal acute febrile illness. In a study done in Sri Lanka, in patients who have been admitted to hospitals, 28% the mortality rate was 28%. And the highest death rate, or the case fatality rate, was found in patients with cardiac involvement. Again, therefore, the clinical diagnosis of leptospirosis is a challenge to clinicians. Why? Because they have extreme variations in its clinical manifestations. There are emerging complications like pulmonary hemorrhage, acute pancreatitis, community-acquired sepsis, and myocarditis. So all these can present in other infections as well. And as I showed you, there is increase in anicteric leptospirosis, and they are similar. Leptospirosis is similar to some of the other tropical infectious diseases such as dengue, hantavirus, and typhus, and also concomitant infections. Therefore, confirmation of the diagnosis is very important for the specific management of the patient, because in this disease we have antibiotics, or we have therapy. So this is a preventable or treatable, curable disease. So the laboratory diagnosis is very important in this condition. Also, early treatment with antibiotics, they have shown that treatment with antibiotics in early leptospirosis has reduced the cytokine storm. That means we can prevent some of the patients going into severe leptospirosis, where severe leptospirosis has a high case fatality rate. Regarding epidemiological surveillance, we can target control and preventive measures as said by the previous speaker. Also, we have to develop policies and guidelines for our country. So now I come to the laboratory diagnosis. So what are the available diagnostic tests, and how you should use them and interpret? The gold standard of leptospirosis diagnosis is culture, because it gives the strongest evidence for confirmation of the diagnosis. But the problem is it is very low in sensitivity. In our laboratory, it's about 7 to 8% sensitive. That means if you send samples, only 7% of the samples are isolated. So it is not useful for the acute management of the patient. Therefore, most of the clinicians don't send these cultures. But I will tell you the benefit of the culture for the country. So when you send the culture, even though it is not important for the patient, it is useful for the management of subsequent patients. Why? It will identify the associations, the clinical manifestations, and circulating serovas. Also, it will tell you whether we are having a new strain in the country, because this happened when we first detected the pulmonary hemorrhage as a clinical manifestation, because we all know that only hepatic involvement or arthralgia, myalgia, and jaundice is leptospirosis. Now it is not. Also, these cultures we can use in our serology panel. It is called the MAT panel. If we use the local strains, it has a very high sensitivity in detecting leptospira patients. And we can use that as a we can test for antimicrobial susceptibility of our strains. That will give you an idea for the clinicians what will be the choice for the disease. In addition, we can determine the probable animal host if we know the strain or the sero1. So time of collection of culture, it has to be in the acute phase, and usually it is positive, mostly it is positive in less than 5 days, but if you are sending a CSF, it is around 10 days. You have to collect the sample around 10 days, 10th day. So clinical manifestation, start of clinical manifestation of fever is very important to determine the test that you should use in this patient. It mainly best before antibiotic treatment, but we have isolated from the cultures even if you have given 1 or 2 doses of antibiotics. So these cultures should be collected into a separate, it's a different liquid medium, not like normal bacterial culture. This is being prepared by the National Reference Laboratory in the laboratory. So if you want to have culture bottles, you have to request for cultures from our laboratory, that is room number 344 at MRI. And the inoculation should be bedside inoculation, because now these organisms are not lot, unlike in other bacteria, they are present in 1 or 2 organisms. So you have to inoculate it then and there. Then you have to transport in a room temperature without direct sunlight. So for culture, we do blood and CSF. So when you request a culture, we give an instruction leaflet. These are the bottles. This is the EMJH media that we send you, colorless media. And if you have to add only 2 drops of blood, and also you have to mix well. Otherwise, the organisms will die and we will have a no growth report. So these 2, they have put lot of drops. So this is the right color. After 2 drops, it should be cherry pink. And you have to keep it in the room temperature. So we have collected and analyzed 24 leptospira clinical isolates from our patients, and the majority of them belong to pyrogenes, followed by autumn analysis. So we have added 6 new genotypes, identify human leptospirosis to the world literature. And 3 of them was isolated from severe leptospirosis patients during the outbreak between 2015 and 2017 in LPTA Southern Province. Then we come to molecular methods. This is very useful for early diagnosis. PCR-based assays have a higher sensitivity than culture and serology in early disease. So what we do is a real-time PCR. It's a cyber green method, which is very economical to the country. It will give a accurate and fast results, and also we can quantify the bioburden of the organism. And this real-time PCR method will give a very low contamination rate. So PCR is available for clotted blood, serum, and also urine. So all this test has been done in-house, and we have validated, and blood PCR is around 82% sensitive with 100% specificity, and urine we have a sensitivity of 52% in a single sample, and specificity is little bit lower than blood PCR. So I thought I will give you some idea in interpreting our results. This is all these from our study observations, the studies that we have done. So when we give a negative blood RT-PCR result in a typical leptospirosis patient or in a confirmed patient, this could be due to, it may not be, you can't exclude, but it may be due to low or short duration of bacteremia in the acute phase. Then maybe the test sensitivity will be, the lower limit of detection will be higher. Or you may have give high number of doses of antibiotics. Now, some may think that PCR will be positive even if you give antibiotics. Yes, it is true. But if the bacteremia is low, then the elimination of the dead cells will be high. So again, we have seen in some of our studies, high number of doses have resulted in low positivity of even PCR. Then delay in specimen collection. So in our real-time PCR testing, higher positivity is seen in early illness, that is usually less than 4 days, but you can send it within a week. Or even at 7 days, we have detected positive results. Regarding use of RT-PCR in urine, as I said before, sensitivity is 52%, and it is in a single urine. Because it's a non-invasive specimen, you can send it, multiple samples can be sent, because in urine, the Leptospira organisms may be detected at different times. Then, significant reduction in positivity in jaundice patients. Now, this is good for anicteric leptospirosis, because if the patient is jaundice, the PCR product will be inhibited by bilirubin. So that is why it gives a reduction in the positivity if the patient is jaundice. Also, it is useful in the first week of illness. And this is very interesting. We have, in some of our studies, we have observed that day of fever or even volume of urine or type of urine, whether it is midstream urine or catheter urine, it will not affect the positivity of the result. And regarding storage time, you can take the urine and you can keep it within 48 hours. That means you can keep it for 48 hours, because we have to run the test within 48 hours. So then the positivity will be not affected. Then we come to serology. One thing I want to say now, because of the limited reagents in the laboratories, for ICU patients we do it daily, but for ward patients we collect and do the testing, because we have to use 5 quality control samples for one test run. So for ward patients, so if you need it urgently, you can just mention you need it urgently, then we will do it on the same day. Then serology. IgM appears 3 to 7 days after onset and peak at 3 to 4 weeks, usually for if you are using ELISA or ICT. And 10% may not develop antibodies. Now, ELISA and ICT, it is useful only as a screening test because, as I said before, they are not our local strains. So the antigens differ and the strains of Leptospira differ geographically. They are country specific. So always you have to validate these ELISA or ICT before you use for patient samples. It's a rapid screening test and it has a low specificity. So it can be performed in a routine lab. So you need only minimal training, and unlike the MAT, we can have IgM, IgG detected separately for in a ELISA. But even if you detect a positive patient sera, it has to be confirmed either by MAT, PCR or culture. This is one of the studies we have done to compare ELISA and ICT, and as you can see, ELISA, this ELISA has 91% sensitivity, but the specificity is low. And we have compared the cross-reactivity among serologic tests for leptospirosis. So these are the serologic tests for leptospirosis, and we have used hepatitis, patients with hepatitis, patient with dengue confirmed, and patient with syphilis sera. And you could see the ELISA IgM cross-react 4% with dengue if the patient is having dengue. That means it will give a false positive for Leptospira. And for ICT, it's 12%. Whereas syphilis sera, if the patient is syphilis, the Leptospira ELISA IgM will give a 20% false positivity, whereas MAT will give only 4% false positivity. This is again the ROC curves for ELISA and ICT, which is done. And you could see that MAT has the best specificity, followed by ELISA and ICT. And also we did a comparison for 3 serological tests under Bayesian latent class modeling in 800 patients. And you could see acute MAT, that means single sample will have a very low sensitivity, whereas specificity is high in MAT. And Leptocheck and IgM ELISA has a good sensitivity, but it is reduced in specificity. That is why we say that ELISA is a good test as a screening test. So now we come to microscopic agglutination test. So it remains as the serological reference method. And MAT antibodies, unlike the ELISA and ICT, we detect both together, and it appears late after 4 days, 4 to 7 days, and persists at low level for years. Now we have SEROVA is the basic taxon for Leptospira. So SEROVA specific antibodies last long than the serogroup specific antibodies. So we did this pathogenic serogroup analysis established in 2014 at MRI, and we use 15 serogroups for our panel. We prepare our own antigens. This is not a kit test, and it is available any day. So we do daily MAT testing, so you don't have to worry. Economically, we are prepared for the test. So strains are maintained in culture and we use only live antigen preparations. It has a very good specificity but complex and time consuming procedure because it's a reference test. So when we give you a positive MET result, this is what we say. So for our country, the significant titer or the optimal cutoff is 320 or more. So what we have done is we have determined by ROC considering our endemicity because we are a hyperendemic country. So, or you can see whether if you send the second sample, you can see whether it is fourfold increase between paired sera or any conversion from seronegative to positivity. That means it's a positive MET. Then what about the sensitivity? Sensitivity of the MET test will be high if you use in paired sera. And this is very useful in epidemiological serosurveys and can be applied to animal species, and we can expand our MET panel at any time or reduce depending on the country's need. So what are the limitations of MET? So just to show you this, so if you send us a blood sample, we check for 15 serotypes. That means we have 15 plates and we titrate for 8 times. So that is why it is very complex, and about 300 times the laboratory staff has to check on the dark ground microscope. So it is very complex procedure. So limitations are possible false negatives, especially in early illness and if the patient died before seroconversion. Also, there can be cross reactions and paradoxical reactions in early illness. That means you cannot identify the infecting sero. Now, MET identifies sero group. So, MET can identify the circulating sero group, not the infecting sero. Why? Because of the anamnestic response. First rise antibody will be the previous exposure antibody. Also, variability of the selected panel. There is a geographic variation, so we select our panel for our country. And this is subjective interpretation of the results, so this needs extensive training and long hours of work. What about the quality of our test? Now I discuss about 3 tests. We always participate in external quality assurance programs internationally for our MET testing, to check whether what we do is correct and reliable. So you get a reliable report. Our all tests are accredited. So this is the first and only government-owned clinical microbiology laboratory in the country accredited to ISO 15189. So not only leptospirosis, all our bacteriology tests are accredited. Also, we do antimicrobial susceptibility. That is not a routine test. It's a broth dilution assay. We have tested 23 clinical isolates. So for clinicians, it is important. Beta-lactams like penicillin, cefotaxime, and ceftriaxone, and ciprofloxacin have shown good in vitro activity against all leptospira strains, and cefotaxime showed the best MICs among the beta-lactams. So severe leptospirosis, it is best to go for cefotaxime because it has the lowest MICs. But for any leptospira, you can use either penicillin, cefotaxime, ceftriaxone. What about doxycycline? So doxycycline had the highest MIC 50, that is the resistance has been shown to doxycycline, our local strains, and many highly resistant. Unlike the beta-lactams, we have seen for doxycycline there were many highly resistant strains. So indicating its limited utility for our patients. Now this is in Western province samples. So just to recap, we are the National Reference Laboratory and we provide laboratory diagnostic for public and private sector hospitals. And these are the available tests: blood culture, microscopic aggregation, real-time PCR for blood and urine, and microbroth dilution assay. So this is just to make you aware. A confirmed patient should have either a positive culture, positive PCR, or a positive MAT. So it's not ELISA, but only these three will confirm a leptospirosis patient. So in summary, we have culture, RT-PCR, and MAT available throughout, because most of them we develop, even culture bottles we prepare, MAT antigens we prepare. So this is available throughout. RT-PCR is also available for blood and urine. So this is a special investigations. We need clinical details, which is very important. The most important is the fever. So fever days depend on whether you need to do culture, RT-PCR, or MAT. Then report delivery, we can email, we can call you if they are written in your request form, fax or hard copy. So just to tell you the current common leptospira, this is in isolates, not the MAT testing. It is the isolates, the pyrogens and autumnalis, and in molecular-based classification, it is Leptospira interrogans, Borg-Peterson-I, and Kirschneri. So these are my references, and I gratefully acknowledge all of them. Thank you.
Thank you very much, madam, for that very informative lecture. So for the final talk of the day, I would like to introduce my consultant, Dr. Vimal Siriuradage, consultant physician from Teaching Hospital, Karapitia. So Sai and I will be doing this last talk as sort of a discussion between the two of us, where I will be representing you as the audience, and we will interview sir as the expert on this clinical manifestation and clinical aspect of leptospirosis. So
Good morning, everyone. And first of all, I must thank Sri Lanka Medical Association and Epidemiology Unit for inviting us to do this presentation. As my registrar, Dr. Ravindra Kodjwak said, this is going to be a discussion, a case-based discussion, and our discussion will be around a case that we came across very recently during our ward work. Now, yes, yes, there are a few things that we need to go through, and I think Ravindra will go through the outline of our speech,
yes.
And I'll hand over the proceedings to
So,
my Ravindra.
So our discussion will be with regards to, now we have a bit of knowledge on leptospirosis with the previous 2 lectures as well. And so our outline will be what is leptospirosis and why we should pay attention to it, the national scenario, the new patterns that we have observed as in our clinical practice, and what are briefly about the therapeutic modalities that are available to us, and also regarding the future of the disease. So just to open our discussion, so leptospirosis is something most of us like to believe to be a familiar disease. So do you think, why do you think we should discuss leptospirosis? I mean, as a...
Yes, it's an important question actually. Now, because it troubles us, so that is the simple answer, because the leptospirosis has become one of the major cause of acute febrile illness in our country, wherever you go. And it is as common as dengue, and sometimes more common than dengue in some areas and during certain periods of the year. Yeah. So because of that, it is important. And also the world stage, according to Tushani, and we had some briefing about the what kind of disease this and the magnitude of its impact on world population. It's in fact more than 1 million of people around the world and causes 60,000 deaths all over the world. And one of the most important thing I want to highlight in our discussion is that, as previous speakers also mentioned, that the leptospirosis disease has changed. So even though it is a disease of more than several decades ago, it was introduced, described in Sri Lanka. Now it is not the original disease that we are dealing with. The disease has changed. Disease has changed in all three aspects of the disease. It's clinical, epidemiological, and demography of the disease has changed. Because of that, we need to learn about this condition more and more. We need to get updated ourselves, because it's a disease of changing disease. Yes. So and also, one important thing that we need to highlight is antibiotic works, and we can treat these cases quite effectively at the early stage if you correctly pick these patients up.
Yes. So we mentioned about this changing pattern. With that in mind, let's go to our patient. She's an 18-year-old girl who is a student, presented to the local hospital quite recently with shortness of breath and fever. And this fever was for about 4 days duration, sir, with body aches, diarrhea, and vomiting for 3 days. She has played in a drain next to a paddy field that is just in front of her house about 1 week back with her little sister. So here, what do you think, sir?
Yes. Now the question is, you want to know whether this is a case of we are dealing with a case of leptospirosis. Yes. Now, according to our Sri Lanka being a tropical country, and with a very high incidence of leptospirosis, our national guideline says that according to our national guidelines, actually any patients who is presenting with acute febrile illness, together with a history of exposure, probable exposure, which is compatible with sort of leptospirosis contaminated environment. So it is, you can consider this disease as a possibility. Now, let me use my slides, because there is a little problem in using slides.
Sorry for the technical difficulties that we had.
Yes. Yes, coming back to our slide, yes. Now, according to this national guideline, any person who is presenting acute febrile illness with high-risk exposure to contaminated water, plus together with two of following: myalgia, headache, arthralgia, conjunctival suffusion, or shortness of breath. any two of these things together with the acute febrile illness and high risk exposure history, you can call them as a case of suspected case of leptospirosis. This is not confirmation, but it is, you can suspect this is a working diagnosis, and after that you can start your management as for leptospirosis. So this patient is presented with acute febrile illness, and she has definitely has a, in the history she has played in a muddy environment, and also she has presented with myalgia and shortness of breath. So these two features are quite compatible with leptopresentation. So it's a case of leptospirosis. Yes.
So, sir, now we are mentioning this high risk exposure to contaminated water, or as we most of the time see in the tickets as lepto exposure. Yeah. Can you explain to us about this lepto exposure? What is it?
Actually, this lepto exposure is a misnomer. And it is the environment that we are talking about now, as Tushani correctly mentioned, the way it spreads, being a zoonosis, any contaminated or polluted environment can be infected with rat or rodent's urine, and then the history of being somebody being exposed to that kind of contaminated environment is the one which is important in the history. So it may or may not be clearly muddy water, mud.
Not just mud.
Not just mud. It may be wet soil, or it may be a flowing river, or it may be just the drain behind your garden, right? It could be anything, because Sri Lanka is being a tropical country with very high rainfall and providing very conducive environment for leptospirosis. We have very we all are at risk, actually.
It's not just one.
Not just one category of people or one occupation or few occupations who are at risk. So that is the fact that we want to highlight among our among our medical professionals. It's not just high risk groups or occupation that we are talking about. It's the whole society at risk given the opportunity that you are going to expose to risky environment. Yes.
So, but considering the initial presentation of leptospirosis, it's an acute febrile illness most of the time. Yeah. So that is something we encounter day to day with the prevalence of dengue as well. So how do we differentiate this?
Yeah. So according to the clinical presentation, actually it's very confusing whether these you are dealing with a any other viral illness like dengue or dengue or any other viral infection or leptospirosis at the initially, because most of these symptoms and signs are similar. But if you do a full blood count, that will show higher white cell count with white neutrophil predominance is in the favor of diagnosis of leptospirosis. Again, if you do CRP, C-reactive protein, which will be high and which will be very high in with leptospirosis, especially in acute stage, the CRP values are unusually high compared to the degree of illness. And also, the early rise of creatinine is a very significant and very distinguishing feature, because in leptospirosis, if I can go back to the slides again, and there are two ways of renal involvement. The one which is very common and very early is as you all know, that leptospira can be found in renal tubules, and the leptospirosis can exert a direct toxic effect to renal tubules, which can cause acute tubular necrosis. This can happen within 24 to 48 hours of illness. So it is that can lead to nephrotoxic effect and rise of serum creatinine. So rising serum creatinine in the early stage of disease is also a feature which will distinguish from other illnesses.
Yes. So we actually discussed why leptospirosis is such an important disease in Sri Lanka, I think, in the previous lectures. And I think we have here a representation of why it is such an important disease.
So this is the map of world map of leptospirosis, where you can see Sri Lanka is in red. Red indicates that the highest incidence of leptospirosis in the world. And actually, Sri Lanka is the second highest incidence reported worldwide, and we are next only to Seychelles. Yeah, we are the highest reported incidence of the world. And in 2008 alone, we have reported more than 7,000 cases of leptospirosis, and out of that, we have had more than 200 deaths.
Yes.
So that shows the magnitude of our problem. Actually, this is our only the reported cases,
Yes.
right?
As Madam mentioned, the
Yes.
true rate is much
Yes.
higher.
So is the Sri Lanka being a tropical country, providing, apart from providing a natural conducive environment for spread of leptospirosis, we have so many other things as well favoring the spread of leptospirosis. Actually, the economic activities and unhygienic disposal of garbage and environmental change and sudden climatic changes, and also the ecological changes and patterns that we recognize in
The economic changes.
economic changes as well. And all these predispose the rapid spread of leptospirosis around the country.
Yes, so I agree that it's an important disease, but there is a mindset among us to think of jaundice in leptospirosis, and this patient doesn't have any jaundice to say. So, do you think still that it is leptospirosis?
Yes, now according to previous two speakers, actually they just mentioned this thing, and the traditional thinking is that we think that when the patient becomes jaundice, you are dealing with a severe form of leptospirosis. It's not so. We all know that 90% of leptospirosis are mild cases. They are anicteric. And when when the jaundice is involved, we call it Wales syndrome, especially when it is associated with renal impairment and bleeding diathesis. And the Wales syndrome is considered to be the severest form of leptospirosis previously. But it's not so. Now, as we all know that any organ or system can be affected by leptospirosis. Not a single organ in the body or system is immune to leptospirosis. Because of that, the clinical picture and the manifestation will be depend on the organ involved. It may be hepatic, it may be renal, it may be pulmonary or cardiac. Right?
All the systems are.
Right. But one thing you need to remember is that when there is a pulmonary involvement, the reported mortality is very high. It is more than 70%. But when it's combined with pulmonary together with cardiac, it goes further high. It can be even 90%.
Now, sir, now you mentioned this pulmonary involvement causes a mortality rate about 70%, which is actually quite alarming. And that is something I think most of us don't have much of an idea about. So can you please elaborate on this pulmonary involvement?
Yes. Now, actually, this pulmonary hemorrhage in leptospirosis first described in Nicaragua in 1995 when they were doing surveillance studies. They found that a cohort of patients who died of confirmed leptospirosis, there the cause of death was not renal or hepatic. It was severe pulmonary hemorrhage. And as they specifically look for renal and hepatic involvement, they found that there are the complications, and renal and hepatic complications are very minimal in this cohort of patients. And later on, many other countries also reported the same incident case, and they name it as severe pulmonary hemorrhagic syndrome.
So
right?
that's a separate syndrome.
Separate entity actually. And in Brazil, going back to their surveillance studies, they found that this phenomenon is an entirely new phenomenon. So they concluded that the clinical pattern of leptospirosis has changed recently. So that is what we are experiencing here in Sri Lanka as well.
Yes. Sorry, we are having some trouble with the presentation. But moving on, so can you elaborate on this pulmonary hemorrhage or the pathophysiology behind it?
Yes, actually, pathophysiology of pulmonary hemorrhage is mainly immune based. Now, in this diagram, if you can see on your left side, you will see a cartoon of to demonstrate normal alveolus. On your right, you get some sort of histological diagram of the same thing, where you can see a greenish tapering thing, which is type 1 pneumocyte, which is in close proximity to pulmonary capillary, alveolar capillary, and which forms together with pulmonary alveolar capillary, it forms the most important structure of the lung, which is alveolar capillary membrane. So what happens in leptospirosis is there is due to the immune reaction, there is an immune complex deposition along the inner aspect of the this alveolar capillary membrane. So that exert a direct immune mediated damage to this alveolar capillary membrane, and that breaks open the alveolar capillaries, leading to hemorrhage. So this is what happens.
No, it's not just because of thrombocytopenia.
No, it's not just because of thrombocytopenia, because we have seen patients who are coming with severe pulmonary hemorrhage, where their platelet counts sometimes normal or near normal, often, right? But still they ended up with severe bleeding. And also there is no significant detectable coagulopathy as well. And the people have found that doing histological studies that there is no significant vasculitis as well. So it's a direct immune-mediated injury at the gas exchange level, leading into pulmonary hemorrhage as well as pulmonary edema.
So it's not just blood that we see.
Yes, in the X-ray, yes, definitely. In the X-ray, you will see shadows. It's not just blood; it's surrounding edema as well because of this pathology. The alveolar type 1 pneumocytes get affected, and there is impairment of clearance of free fluid in the alveolus, so that the alveolar clearance get defected, and so that the fluid get accumulated. In addition to blood, you get edema, so that you will see. We can go through some of the X-rays later on, and there you will see complete whiteout of lung fields in the chest X-rays.
So now we talked about this pulmonary involvement and the added mortality with cardiac involvement. So what is this cardiac involvement, and what can we do to detect it?
The problem with cardiac involvement is there are no specific symptoms that will suggest a cardiac involvement. Often these patients complain of chest pain, shortness of breath, and sometimes they can go into severe acute pulmonary edema as well. All these things can be attributed to cardiac involvement. But if you happen to do ECG, that will definitely show changes. Right? So it's very important to do ECG changes in acute leptospirosis, because often there are T depression and ST segment changes. Sometimes ST segment elevation can happen, which will mimic acute ST elevation myocardial infarction as well.
But that is not due to ischemia.
It's not due to ischemia, and in severe leptospirosis, when there is a cardiac involvement, there are significant ECG changes. Together with there is enzyme rise as well. We have seen patients with severe cardiac involvement with more than 1,000 or many folds of 1,000 rise of troponin, as well as if you do echocardiogram, that will show regional as well as diffuse wall motion abnormalities.
So that might mimic a true
definitely that will definitely mimic true myocardial infarction. But it's not so. This is a part of
indication for thrombolysis.
Not indication. Definitely, it's not an indication for thrombolysis, and it's a part and parcel of this disease.
Yes. So now we discuss how dangerous this disease can be, but we don't see it as often. We don't see most of the patients developing this problem. So why do you think that is? Is it due to
yes, now actually we learned this thing from COVID, and if I can just take an example from COVID, in COVID we also saw the same thing, and it's the majority patient develop mild illness even if they get infected, and only a very fraction of people develop severe disease. That is, in mild disease, what happens is they get infected, and they produce immune reaction which is well regulated, and it is quite adequate enough to control their symptoms and severity of illness, and they come out of the illness, come out of the problem. But in severe cases, what happens is their immune reaction is dysregulated, overwhelming, out of proportion. So this immune reaction can lead to the same way in COVID as well, the cytokine storms, and which can lead to sepsis and then multi-organ failure. So this happens only in a genetically susceptible individuals. So this has a genetic basis actually, if you go to very detailed. So it's a genetically susceptible group of people only develop severe fulminating or multi-organ involvement leptospirosis.
It's not just the virulence of the disease, but also the genetic susceptibility.
Genetic susceptibility also plays, but yeah.
So, so you mentioned now the pulmonary hemorrhage syndrome was first described in Nicaragua. Now, what is the condition in Sri Lanka?
Yes, actually, the previous speaker also mentioned a little bit about this thing. And way back in 1977, Dr. Ramachandran has reported 7 confirmed cases of pulmonary hemorrhage in leptospirosis from Bragama. Actually, that was the first report where he has nicely described and confirmed an autopsy finding, also gone into details of this descriptive details of pulmonary hemorrhage. Since then, Sri Lanka has been reporting case series of pulmonary hemorrhage. And in particular, in 2008, Teaching Hospital Karapeti has reported an autopsy series where during that year, there have been 25 deaths due to leptospirosis. Out of these 25 deaths, the autopsy revealed 21 deaths were due to pulmonary hemorrhages. So you can see how
quite a high number
alarming and how the impact of this disease according to the mortality wise, right? And in 2019, we reported from Karapeti again more than 100 confirmed cases of pulmonary hemorrhage in leptospirosis. So it's a well-established clinical entity in Sri Lanka.
So now we have described how lethal this can be, and I think Madam also discussed the current state of leptospirosis in our country. So what's your opinions with regard to our current situation in Sri Lanka?
Actually, now I think one slide. I think we skipped one slide. Now that's okay. Now we can actually
Slide 26.
correct. Right. Actually, the problem is what we need to highlight is that the Sri Lanka's problem in leptospirosis is the 3 things that we need to highlight. One thing is that the change of epidemiology and the demography of the leptospirosis. And the other thing is change of clinical pattern, which has contributed to higher incidence of mortality in Sri Lanka, especially pulmonary and cardiac involvement has becoming more and more common. And because of that, the mortality rate is going up. Yeah. And yeah.
So, yeah. So we agree that leptospirosis is quite severely underestimated in our country. So, I think Madam also covered this slide why leptospirosis is quite underestimated, because we have our notification system and why it has gone to that level. I apologize that we have some technical problems.
Yeah, actually, why it is underreported? You raise an important question, important issue, because it's from the clinician's point of view, the existing reporting system, Tushani, is a bit very cumbersome, and according to the board work, actually it's a paper-based reporting system, and it is quite outdated, and it is very difficult to motivate our young generation to do these things. That is the actual thing, and we have to face that. So we have to find solutions for that rather than blaming the juniors. So it is one thing. And the other thing is where most of these patients are being suspected to have leptospirosis. When you treat, they recover very quickly, right? And then you forget about the reporting part, and the patient will be discharged, and the reporting part will be forgotten, right? And the third thing is, since we don't have a confirmation of leptospirosis, it takes time. At the initial stage, you treat them as leptospirosis, you suspect them and you treat them as leptospirosis, patient become better. But still, you are not confident, that clinicians, as clinicians, we are not confident enough to document it as a case of leptospirosis. That is also plays a part, because it's not being properly documented in the BHTs. So because of that, later on, the patient will be discharged as any other case of acute febrile illness. And apart from that, actually, the other most important thing is that the majority of these patients who are mildly symptomatic goes to outpatients and general practitioners. They are obviously not being included in reporting. And also the social impact due to mortality and morbidity is only happens to mainly the social classes, also who are quite underprivileged and economically backward. So because of that, with the media attention and the overall attention paid based on mortality and morbidity of this impact of disease is not being properly highlighted.
And coming back to the topics, now leptospirosis, we say it's quite...
skip that slide.
Yeah. So, again, we are having a bit of a difficult time with this.
Yeah. So Ravindra is going to the podium, because we are facing a little bit of problem in handling the slides when we are here. Okay.
Okay, sir. So a little bit of a distance anyway. So now again we are seeing a different clinical pattern at this day and age in our country. So why do you think that this change is due to a change of zeros, or could it be due to something else?
Yes, actually that is what we are trying to prove, because according to Lilani also, we together, Lilani and the MRI, and we are trying to prove that this pulmonary hemorrhage of due to leptospirosis is whether is associated with a different new zero. But it's, we are short of lot of data. And because of that, I don't think at present we can say whether this the new severe complications are due to severe more virulent strains. But in other countries also this has been reported. In Brazil, they have found that in one city called Salvador, where the mortality is mortality is mainly because of the acute renal failure. But in another country called Sao Paulo, where the mortality of leptospirosis is mainly due to pulmonary hemorrhage. So same thing. In Sri Lanka, we also observe that the pulmonary hemorrhage due to leptospirosis and the mortality and morbidity also very high in wet zone, especially in Galle, Madara and Ratnapura district. We find this problem, and also the increasing cases rates of mortality. It's
Yes.
not sure whether it's due to a specific zero involved, but it's time that we should look into that.
Given our audience, I think we can ask them to go in for a research.
Yeah, definitely. There's a tremendous opportunity for researchers in the country to look into this aspect and see whether there is a different type of virulent zero was involved with these complications.
Okay, now coming back to our patient, sir. So she was admitted to the local hospital and she was in circulatory shock on admission with low BP with severe tachycardia. And they have started on inotrope support. And as we mentioned before, with their local knowledge, they have made a probable diagnosis of leptospirosis, and she was started on both IV ceftriaxone and doxycycline. And what do you think about this approach, sir?
Yeah, it looked like this is a case of severe leptospirosis, and clearly because of the patient's the clinical picture is becoming more acute and more unstable. Yes. So this won't happen in a mild case of leptospirosis.
This severe tachycardia and
definitely
hypertension.
We are dealing with a case of severe leptospirosis.
Yes. Yeah. And how do we now, we have made the clinical assessment saying that this is severe leptospirosis. How do we organize, in an organized manner, how do we assess this patient?
Usually we don't have a validated, in our country or in our setup, we don't have any validated tools to assess severity of these patients at the moment. But what is important as clinician is to recognize this particular patient you are dealing with is a case of mild leptospirosis or severe leptospirosis. Yes. That's all. You can simplify as that. Once if you think if you suspect a case of leptospirosis, yes, try to identify whether you are dealing with a severe case or not. That's all. Now that can be done quite easily and effectively done by clinical observation.
Yes.
Right? And in severe leptospirosis, one of the commonest thing and very frequent thing that happen in on the beginning of the illness is the hemodynamic instability. They become hypotensive. This is because of the sepsis caused by the severe immune reaction. As I mentioned before, these cases of severe leptospirosis develop severe immune reaction. As a result of that, they goes into a state of sepsis, leptospiremic sepsis,
yes,
and which can associate with hemodynamic instability, causing low blood pressure. So hypotension quite important. As in our patient, hypotension is a very early sign of patient going into developing into a progressing into a severe form of leptospirosis. Yes. In addition to that, oliguria again is a quite good indicator of severe leptospirosis, and also hyperkalemia as opposed to hypokalemia, which is the commonest common form of electrolyte abnormality. You see hypokalemia, but if you happen to see a patient with hyperkalemia, that indicates that you are dealing with a severe form of leptospirosis.
So icterus is not something that
definitely it's not. Icterus is not synonymous with severe leptospirosis. It may be a manifestation or not, but you need not wait until patient become icteric to
that the patient is in severe leptospirosis.
Yes.
So again, back to our patient now. Considering her severe tachycardia, shock, and she also had a severe tachypnea. Therefore, the local team has arranged an urgent chest X-ray. And because of the severe tachypnea, they have arranged a ABG as well. And they have noticed that ABG showing type 1 respiratory failure and also some X-ray changes. And they have suspected of pulmonary hemorrhage, and she was started on methylprednisolone on steroids. And also, considering the limitations, they have contacted the tertiary care hospital, which was TH Karapitiya, and she was transferred there promptly. So now, in this patient, sir, so I believe that the local team has done the right thing. So what are these features of pulmonary hemorrhage?
Yes, quite rightly they have done the right thing. And when there is a pulmonary involvement, first thing that the patient develop, in addition to low blood pressure and other things, the high tachypnea. The patient started breathing very rapid and fast, and the patient ultimately complains that the difficulty in breathing, dyspnea, patient become dyspneic. So that's a very early sign of pulmonary involvement. And then as things progress, patient might develop hemoptysis. But usually, most of the time, patient hemoptysis is a late manifestation during the course of pulmonary hemorrhage. So don't wait until patient develop hemoptysis to diagnose leptospirosis pulmonary hemorrhage. It is the tachypnea and respiratory distress is the one which is very important to suspect pulmonary involvement. And in addition to that, often these patients complain of chest pain, and probably they might have features of acute pulmonary edema as well. And if you happen to do arterial blood gas as they have done in Balapitiya or local hospital, the type 1 respiratory failure, especially arterial hypoxia, is a very early finding in pulmonary involvement. The chest X-ray changes can occur, but it takes time.
Yes.
So this is a X-ray of typical chest X-ray finding of a patient with pulmonary hemorrhage, where you can see small nodular opacity that may progress into larger coalescent areas of consolidation, which we call it, radiologically we call it cotton wool shadows, which are usually bilateral, often inferior and peripheral. So that is how you, those are the X-ray findings
that we should look for.
We should look for. It's mainly bilateral, often inferior and peripheral.
Yes. So our patient was immediately transferred to TH Karapitiya, and on admission itself she was extremely tachypnic, and she was on face mask oxygen with a respiratory rate of 48, and repeated ABG at ETU also showed a carbon dioxide washout with a type 1 respiratory failure. Urgent chest X-ray was also done, but however, as the patient was progressively becoming dyspneic and was unstable, she was intubated at the ETU itself. And so we can go to see the X-rays.
Yes, even the first X-ray, it's not clear on the screen, but it's very clear on the display. The first X-ray also shows bilateral nodular shadow in the chest X-ray, especially peripheral, inferior and peripheral areas. So that's why at the local hospital they have decided to treat this patient as leptospirosis and treated accordingly. And the second X-ray, which was done a few hours after at the Karapitiya hospital, few hours
about 6 hours.
About 6 hours apart, can show the difference. There is a remarkable difference between the first X-ray and second X-ray, which is not very clear on the screen again. And so that shows a very rapid change. Of radiological features from first X-ray to second X-rays. This pulmonary involvement can be very severe. This is another patient. This is not this patient's X-ray. Another patient who came with a similar kind of presentation, the acute febrile illness, and he started coughing out blood in the ward. And we went into a respiratory arrest. We had to intubate him in the ward itself. So this is what we saw in the ward, and when we intubated, the blood started coming out from the ET tube. So he ended up with a severe pulmonary hemorrhage.
That happened in such a small time.
Such a small time, and within minutes and hours, these patients deteriorate. And in a resource poor setting, the survival of this patient will be definitely
very
a problem.
less. Yes. So our patient, and considering now when she admitted to the local hospital also, she has not passed urine, and she continued to have reduced urine output, and her serum creatinine also found to be rising. And then she also, during the ICU stay, she has reduced hemoglobin, where we had to transfuse her. Her lowest hemoglobin value was 7.3. with lowest platelet was 32, but on admission it was around 70. CRP also 138, but it continued to decline with antibiotics. The highest serum creatinine was 272. And however, in this patient, we didn't have to give platelets, and she did not need any dialysis as well. So, regarding the treatment of disease, what are our options?
Now this patient came as a suspected case of leptospirosis, and as you suspect a case as a leptospirosis, there is no, there is a compelling indication that you can start antibiotics, right? So early initiation of antibiotics is very important, especially with regards to which can prevent the future development of complications, especially renal complications. And so you can start with oral antibiotics, but since this is a case of severe leptospirosis from the beginning, I think IV antibiotics should be the choice. So IV ceftriaxone, IV penicillin would be a choice, but according to Lilani, the IV cefotaxime would have been ideal in severe leptospirosis. So the next option, when the patient develop features of pulmonary hemorrhage, that is tachypnea, acute respiratory distress, then you have to decide on steroids. That is, steroids has proven benefit with pulmonary hemorrhage. Especially this study has been done by Professor Kularatne and his team, and this has been the evidence has been proven beyond doubt that the IV methylprednisolone is going to be effective in this kind of pulmonary patients with pulmonary hemorrhage. And it's being widely used, and for 500 milligram daily for 3 days, followed by oral methylprednisolone can be extended up to 5 to 7 days. So what is important in initiating steroids is it has to be started quite early in the disease, as you suspect or with the earliest sign of pulmonary hemorrhage. Because when you start methylprednisolone later on, is late stages in the during the course of illness, especially when the patient is several days following admission to ICU,
yes,
you know what complication you are going to
our
face.
most dreaded complication, ventilator-associated pneumonia.
Associated pneumonia will be a very huge problem if you happen to start these steroids later on. But it is the steroid should be started quite early in the disease, which gives quite effective, very good results.
Yes.
And the next option, the newer option that we tried at Karapitiya was therapeutic plasma exchange. Actually, what happens in leptospirosis pulmonary hemorrhage, as I described before, it is an immune-mediated injury that happens in the end organ. So if you can somehow remove this unwanted toxic immune products from the bloodstream or the plasma of the patient, so that could be very positive.
It would be quite logical.
Yes, quite logical. This is exactly what happens when you do therapeutic plasma exchange, where you remove the plasma with immune products, bad immune products, and replace it with fresh plasma. So we did a study on this, using this method. We employed this method on more than 80 patients, and we actually recorded survival. We actually achieved more than 70% of survival. Right? Usually
which is quite remarkable.
Which is quite remarkable. Usually it is more than 70% of mortality in this kind of this entity. But we achieved more than 70% of survival. Of course, one thing I have to mention is that this is not a randomized control study, because you know the difficulty in doing a randomized control study in this type of a very critically ill patient in an ICU setup.
Yes.
So there is
opportunity again for
our researchers, if you can embark on this aspect of the management of this thing. But it is now it is being gaining popularity around the country, and it's being used quite frequently, and often it gives
better results.
Again, the initiation should be quite early in the disease. If the patient comes late with lot of complications, then again the validity or the
outcome will be anyway poor.
Effectiveness of this treatment model is again very limited.
And something new that we learned through the COVID era is ECMO.
Yes.
So what is the place for ECMO, sir?
Yeah, that's right. Actually, only ECMO machine which is available in Sri Lanka is at Teaching Hospital Karapetiya, where we have used this technique to treat these patients, especially patients who are not stable enough to undergo therapeutic plasma machine, and also their condition is quite severe, and where the ventilatable or the usable lung tissue is
lung mass is quite low,
minimal. So few of those patients treated with ECMO, and we reported good results. And one study done at French Union Islands have also shown that 6 out of 8 patients who were treated with ECMO have survived. So it's a very technically demanding, very expensive, very tedious procedure, but still it is good for the selected patient, because we are dealing with this category of patient at the actually worth treating for, because it's very rewarding. And also once they are treated and when they recover fully. There are no long-lasting sequelae as a result of this complication. Because of that, I think the priority should be given to develop this aspect of treatment modalities as well in our country.
Yes. So coming back to our patients, now she was in the ICU, and we have promptly started plasmapheresis on the day of admission to tertiary care itself within few hours, and we continued for 3 cycles daily plasmapheresis, and 3 doses of methylprednisolone was also given, and as initial dose was given at the local hospital. And with this early treatment and prompt treatment, she showed quite remarkable recovery, and we were able to extubate her on day 4 of ICU care, and we could discharge her to home after 2 days in ward care. And her kidneys also recovered quite remarkably without any lasting complications. So this was X-ray at discharge.
Yeah, you can see that X-ray is quite clear. I mean, has become normal, almost normal, and her parameters are also quite normal. And actually, this patient was discharged from our ward 3 days ago, I suppose.
Yes.
Yeah, 3 days ago. And actually, we took this patient for our case vignette, because it's in any setup, this patient won't be considered or suspected to be having leptospirosis, because she presented because of presented to the hospital because of the shortness of breath, and her other complaints were the fever and diarrhea. So you would not suspect leptospirosis in a schoolgirl, 17 or 18-year-old schoolgirl coming with a shortness of breath as a case of leptospirosis, right? And because of this exposure history, actually we initially from the local hospital, even they suspected this possibility and attended on time to her complications, and quite correctly correct decisions were taken, and because of that she was safe and sent home. And this won't happen in every time. Actually, when the patient admitted to a resource poor setting, and also when the knowledge about or the experience about this kind of presentation is lacking, so this is where the mortality goes high. And also the delay in referral or admission to the hospital.
Yes.
So there is a limit that this condition can be treated. Beyond that, it is irrecoverable. And any delay in taking decisions and starting effective treatment would be very detrimental.
Yes. So as we see, it is a difficult disease to treat with time, and when it's complicated, it becomes such a headache to all the clinicians. So prevention is anyway better than the cure. Yes. So little bit about the prevention, sir, what can you say?
Yes, prevention can be done actually in two ways. One thing is prevention of getting somebody exposed to contaminated environment. If it is difficult or inevitable, your exposure is inevitable, yes, you can prepare for that and take prophylaxis. The prophylaxis is quite effective. To Shani, so far, the doxycycline works very well in our locality. And people who are regular farmers who take doxycycline are actually free of disease. And even if they catch a disease, the severity, the complication, they ended up minimal or minimal severity. So the prophylaxis still works, doxycycline still works, and it should be popularized among the risk groups as well as people who are going to exposed to contaminated water. And one important thing for us even, now post-exposure is also important. And if you happen to expose to a flood water, say sometimes, even in Colombo you can get accidentally or unexpectedly
flash floods.
To flash floods, and flood exposure is a very high risk, risky exposure. And once you expose, as early as possible, if you can take 2 capsules of doxycycline, that has been shown to be effective. So it is post-exposure also, it is effective if you can popularize these things and give publicity. And this is the
old campaign posters.
Posters from the Ministry of Health. Actually, this need to be updated, because when you see this poster, it is mainly the farmers you are focusing, and it is people tend to think, even the doctors think, then this is a disease of farmers. This is a disease of agricultural environment of the communities. This is not a disease of in the city. This has come to the city actually. Yes. So it is in the city, and it is among all of us, and it can spread like a wildfire at one day when you you're having some kind of floods or something like that. That will be a trigger, and there will be a huge outbreak of leptospirosis if you don't pay much attention.
And as Madam mentioned of this ecotourism and
yes. So it is a high risk, very high risk exposure, because most of these patients who goes in camping, hiking, or whatever the eco type of this thing, they are not immune, unlike the farmers who are usually getting exposed, frequently exposed, and they have gained immunity. But these non-immune people are getting exposed to this risky environment is again very high possibility that they ended up with
severe disease.
Severe disease, especially, yes.
So to summarize, I think we have quite well established that leptospirosis is a killer, and we often overlook it. So new and severe disease patterns have been emerging, and there's a new population at risk. So early recognition especially in severe forms, is quite important. And also we can strengthen our primary preventive sector. And also we would like to highlight that there are immense research opportunities as well to propagate our knowledge about disease in our country, because even though we are the second highest in the incidence, we have the lowest amount of articles that are published regarding this disease. Yeah. So thank you, and that concludes our technical session. If we have any questions, I think the expert panel is open for questions.
Okay, thank you. Yes.
same way, is there any move to do something special to prevent leptospirosis? Is there any move to do something special to prevent leptospirosis?
Not at the moment, and actually creating a separate unit or a control room, it should be done at the national level at the surveillance unit, the epidemiology unit, because we are having the surveillance data, and our options are like we have the collaboration with the clinicians, the MRI, and at the moment, since this is another disease for the community, the communicable disease, so we need to gather the evidence, at least to check what is happening. So as Sir said, although we are the second highest in the world with the highest number of cases, we do not have actually the research and other surveys to draw upon. So I think the epidemiology unit is the best place where we can start this off. Already we have done like since 1974. This has been a notifiable disease, and we see that some progress has been made. There are guidelines developed by the epidemiology unit and the special surveillance report, and our notification system, although cumbersome, even during the 2020 COVID-19 pandemic, we saw that we got about 8,000 notifications from the hospital. So we have to look ahead and improve our surveillance as well as our clinical mechanisms before we think of starting another unit, because you can't start from scratch. So we have to build upon what we have already started. Thank you, sir. Thank you very much.
Yeah, I think as you mentioned, very important factor and very highlighted that. And I don't know whether it's going to be the perfect solution, but somehow there should be a special consideration about this illness, because it's killing people around the country, especially in the wet zone of the country, is being affected, and people are not aware of the danger of this illness, and especially the medical community is also not much aware of these newer trends of this disease. So somehow we have to go into the public as well as to the medical community, start educating our doctors regarding the various different presentations and different treatment modalities available, and how to detect these problematic cases and refer on time.
So there are several questions from the online participants. One has questioned, can we get an idea of the lepto serotype from the presentation of the patient?
No, that is what so it's a very difficult question to answer at this moment, because we don't have data actually. And MRI Lilan is trying to do some study on these things, but we have found only 6 positive culture-based studies so far from this area. Out of that, only one was linked to a severe form of pulmonary hemorrhage. Still, it's a very early stage of linking this particular serotypes with this severe complication. It's too early, I would say.
We don't have enough data.
Yeah, we don't have enough data. So that's our duty to gather data, adequate data, and go for this identification of serotypes.
Thank you, sir. There's another question. I think this is directed at Dr. Tushani. Do we have the surveillance system to monitor uptake of doxycycline by farmers during specific periods?
Actually, the doxycycline is distributed to the medical officer of health, and the PHIs usually distribute the doxycycline among the farmers. Monitoring in the sense we distribute, as I mentioned, the uptake is at the moment it is up to the farmers. So we are not too sure whether they take it or not, but according to our clinicians, Dr. Uluwathage mentioned that he has noticed, he has observed that the people who take the doxycycline correctly for the correct duration, actually they are safe from leptospirosis. So to be honest, we don't have a monitoring system to monitor whether they are taking the doxycycline, but we have a system to ensure that it is distributed. Thank you.
Thank you, madam. There's another question. So you want to add? Yeah.
Actually, I want to mention few things regarding this prophylaxis, not directly to prophylaxis. The difficulty in implementing these things or the difficulty in countering the severity of this problem is quite complex, because most of these patients we come across in at Karapiti Hospital who develop severe pulmonary hemorrhages are not regular farmers. Some of them are farmers, but they are not regular farmers. They are maybe doing very odd jobs, and quite infrequently, or accidentally, they would have got exposed to risky environment. They are the people who ended up with this thing mostly, not the farmers who are regularly doing the farming work in the muddy environment. The other thing is, and it's not just farming community, so you can't just limit but distribution of these things to farming community alone, because it will do some good to farming community, that's good. But anyway, that's not going to curtail or eliminate this condition by giving doxycycline. It is so wide, and that it can be so very brief even. The patient might not even remember. Actually, this our case witness also, that child didn't come out with the history of being exposed to that environment, or the exposure being laid in a muddy environment. So that was a very brief and subtle sort of exposure.
I can add to that. There was one patient about 2 months back with myocarditis as well in leptospirosis. She has just gone to the nearby paddy field just to pluck some bananas. So she was just there. That is the only exposure that she complained of. So they don't even consider it as exposure unless we ask it.
And the other thing is the environment. Usually, the people who get exposed to regular farming fields are not at a high risk. Where the highest risk is associated the marshy lands, where not regular farmlands, right? Abundant areas, especially abundant farmlands, like in what happened during this few last year, a year ago. We started cultivating all these abundant paddy lands and other lands. So people started getting exposed to these virgin sort of lands more frequently. And there the concentration of organism probably is very high. That is why, especially when a patient comes with a very severe form of leptospirosis, there's a usually association between this kind of exposures. It's not the regular farmers who are mostly at risk as far as regards to severe form of leptospirosis. But I wouldn't say that it's not the farmers who are being affected most, but being the largest population at risk is farmers, is quite correct. But it's not just farmers.
So there's a question from Professor Jennifer Pereira. This doxycycline resistance, is it a concern for this program of prophylaxis for farmers?
We may have to look into this, but at the moment, one of our major preventive activities is the distribution of doxycycline, because we have seen. So I think we need to look into that as well.
I can partly answer that question, madam. And this is, there is no resistance actually. She mentioned it is just the raised MIC, high MIC. Now we have to see specifically whether it's associated with resistance to doxycycline. But when you consider, actually when I'm speaking of my experience with the use of doxycycline, we have not seen any cases. We haven't come across any patients who is resistant to doxycycline. Doxycycline is still quite effective for leptospirosis. What do you say?
I think we don't encounter many patients who have taken prophylaxis and found to have leptospirosis. In our clinical practice, we don't see many patients who are coming and saying, I took doxy and even after taking doxy, I got this illness. So in clinical practice, what we see is people who have not taken doxy are the ones who are getting the leptospirosis. So in a way that it means that the doxycycline works.
The popular saying among farmers is that I have been in farming for 30 or 40 years, but I didn't get this disease. So why should I take this prophylaxis or this doxycycline now? Because they are they have been not taking doxy for their life. So then, is there any validity to that statement? Like sir said, that regular farming are less effective, and is there any concept or immunity
Yes,
for lepto?
definitely, yes. Definitely, there may be, but even though we have not proved, the regular farmers, there are so many cases now. In this case, it's quite interesting if you go into the whole detail of this patient. Actually, this girl has gone with his brother and mother,
Yeah.
probably brother who is a farmer,
Yeah.
who is a regular farmer, who together with him, he has gone to this place, and the brother is not affected, right? And again, we have seen once quite young patient, a 14-year-old schoolboy came with a severe pulmonary hemorrhage. That was the first child I came across with pulmonary hemorrhage from Imadur, where he has played the same paddy field where his father was working. So the father was not affected, but the child got ended up with severe pulmonary. So it may be because genetically predisposition as well as immunity may be playing both. Right?
As we highlighted before, it may be the genetic susceptibility of the individual as well, because in COVID also we have seen that several patients developing quite a different way immune reaction. So as we said, this pulmonary hemorrhage and all these complications are mainly immune based. So their immune reaction, disproportionate immune reaction is the one that causes quite severe disease. So I think more than immunity itself, it's just that the patient's own genetics that plays a major role. So in farmers taking doxycycline, we are trying to circumnavigate the risk for a person to have the immune reaction without letting them have the infection, because otherwise it would be trial and error. You will say that I won't get it, but at one point you may get it and you may develop the disproportionate immune reaction. So that's the idea. So we cannot discourage taking the prophylaxis.
According to what you have seen, sir, would you say that more younger people are having those more unusually severe diseases?
No, I can't say that, because we highlighted this case because it's an unusual case, so that we can induce the curiosity among your audience. Not just we come across a lot of patients with severe complications among young people. No, it's not. This one of the,
Younger ones, but we even at the moment we have about 3 patients with leptospirosis who are not that severe in very various age groups.
Yes, it's not the young people who are mostly at risk. Definitely we can say that unless you have been exposed to a risky environment, it is the adults, still the males who are mainly manual workers, who are very active in the field, ended up catching this illness. Yes.
Thank you very much, sir. I think we have a plethora of questions from the online participants as well, but due to time constraints, I think we have to stop at this point. But one question from me, sir, since I am from the dengue unit, I think I should ask this question now. In dengue, because now if a febrile patient comes to a primary contact doctor or a general practitioner, one of the first things that they will suspect is dengue. So for primary contact doctors or primary physicians, what will be your advice, or what will be the key points that you emphasize for primary care doctors to identify leptospirosis?
The one thing important is that just to see whether they have this the history of risky exposure. Often this the traveling distance and trip going on a trip or kind of unusual experience or exposure in the recent past. If there is any association of that kind of exposure, yes, you have to consider leptospirosis as a differential diagnosis. Yes, so that is the only thing you can go for. And if you are in doubt, so why don't you do some basic investigation like blood, full blood count, CRP, and a serum creatinine. Right?
Thank you very much, sir. I think we had a very thought-provoking session today, very engaging session as well. So to conclude the proceedings, I would like to invite Dr. Dhanushi Vijaykorn from the Epidemiology Unit to deliver the vote of thanks.
Thank you, Dr. Lahiro. On behalf of the Epidemiology Unit, I would like to thank the Sri Lanka Medical Association and its president, Dr. Vinya Aryaratna, for organizing the today's session on leptospirosis. I would also like to extend my sincere thanks to all the distinguished speakers, Dr. Tushani Dabrera, Dr. Vimala Siri Uluvattage, Dr. Lilani Karunanayaka and Dr. Ravindu Kodituaku for taking time out of their busy schedules to come and share their knowledge and experiences with us. Last but not least, I would like to thank all the participants, both online and physical attendees, for joining with us today. Thank you all and have a nice day.
One last item before we conclude, I would like to invite Dr. Lushan Jayasuriya, former president of Sri Lanka Medical Association, to deliver the letter of appreciation to the following dignitaries. Thank you very much, everyone. We will see you in another expert talk soon. Thank you.